Thanks, Eric, for the introduction.
Perfect.
So my name is Dritan Agalliu, and I'm an associate professor in both the departments of neurology as well as pathology and cell biology. And so I'll present here, today to you together with Kiran an effort that has been a large effort from both departments of neurology, pathology and cell biology, Department of Medicine, Infectious Disease, and Department of Radiology to try to understand the neuropathology in the brain in COVID-19 cases in an effort to understand sort of the mechanisms of disease in particular and correlate these with neurological it's found in these patients. So even though COVID-19 is a clear respiratory disease, there have been a large number of reports that indeed the disease is associated with neurological manifestations. A year ago, when the disease started in Wuhan, China, there were reports that about 36% of the patients that had COVID-19 manifested with neurological symptoms. And then this picture became a little bit different a month later when the Spain ALBA COVID cohort released data that about 57.5% of cases had actually neurological manifestations. But this number has changed very dramatically. And in fact, different groups and different cohort studies have actually reported that the neurological manifestations in COVID range very, very dramatically. So for example, there have been cases, there have been studies where about 4.2% of patients develop neurological manifestations. And then to the most dramatic study from the ALBA COVID group in Spain that reported about 57.4%. And in fact, this small number was basically a large survey by 56 hospitals in China later, which found that really only about 4% of cases had true neurological manifestations. So the neurological manifestations range very dramatically, and they can be found both CNS, the central nervous system, and the peripheral nervous system. And so here I've sort of illustrated very briefly data taken from this recent review in Nature Review Neurology about roughly the range of the percentages of the neurological manifestations that are seen in COVID-19 cases. So dizziness is a quite common manifestation found in about 46% of cases. Obviously headache as well, and impaired consciousness. And then as well as stroke. Whereas some of the other symptoms such as the seizures, confusion, ataxia, and agitation are seen in a smaller fraction of these cases. And then in addition to this, there's been reports of basically a large number of manifestations of the peripheral nerve system. Obviously, a lot of you are quite familiar with the anosmia because that has been sort of a main feature of the disease. And it's been reported to be present in about 21.7% of COVID-19 cases, dysgeunia, 10 to 22% loss of taste, and then the other PNS manifestations. And obviously the presence, and there have been reports also of psychiatric manifestations. There was a study published in London that really has reported severe psychosis in in a subset of COVID-19 cases. So I'm sort of more a vascular neuroscientist, and I'm really interested generally in terms of trying to understand the mechanisms by which viruses and immune cells can enter the brain. And so this was really an important and interesting question to think about, because when we think about the central nervous system, unlike a lot of other organs, the central nervous system is equipped to protect itself from viruses and immune cells. And it does so by the presence of the large number of specific built-in barriers. And these barriers come in different forms. One is the barrier that exists between the edge of the brain and the meninges, called the meningeal barrier. But even inside the brain, there are also specialized barriers. One is a barrier present at the blood vessels, the vascular barrier termed the blood-brain barrier, where endothelial cells that line the blood vessels of the central nervous system form these specialized tight junctions that prevent free diffusion of molecules, but they also basically prevent the entry of viruses and immune cells in the healthy brain. In addition, even in specialized organs, for example, such as the choroid plexus, where the vasculature is quite leaky, epithelial cells that form the choroid plexus form a beautiful barrier that restricts basically the movement of the viruses and immune cells from the vessels into the cerebral spinal fluid. And so from the get-go, when one thinks about a disease that manifests with neurological symptoms, one is interested in trying to understand potentially what are the routes by which the virus may potentially invade the central nervous system. And obviously, when we think about these questions, there are a few routes that one can potentially envision of how a virus like SARS-CoV-2 may enter the central nervous system. And one of them is obviously the olfactory route. As we know, the virus has a large tropism for the nose and the nose-associated olfactory epithelium, and it is found here in very high loads. And in this region reside the olfactory sensory neurons, whose axons project into the olfactory bulb, the first relay in the central nervous system. And so it's known that in the COVID-19, the virus has high loads in the nasal cavity. And we know that 1/3 to 2/3 of patients experience a sudden loss of smell. Even though the loss of smell is not permanent, it is known that indeed the coronavirus can kill the nerve cells. And so this may represent a tremendous way by which the virus can enter the central nervous system. And in addition, in other diseases such as neuroinflammatory diseases, it's also known that immune cells can traffic along the olfactory routes. And so it is possible that indeed macrophages loaded with the virus can traffic through this route to enter the central nervous system. And so the second route that one can think about is the vascular route. And in this route, this has been postulated as a route by which the virus may potentially enter the central nervous system. And that's illustrated here on the right. So it's known that indeed in COVID-19, there is a high number of, there's a very severe immune response. There's a large number of inflammatory cytokines that are present in the bloodstream. And a large number of these inflammatory cytokines are known to disrupt this tight blood-brain barrier. And we know this from studies of multiple sclerosis or other forms of autoimmune encephalitis. And so potentially one can envision that the disruption of the cell-cell junctions between endothelial cells that normally maintain an intact barrier could be sufficient to allow either the virus to cross this barrier or immune cells that are loaded with virus to traffic and enter the central nervous system. And then a third route that has been postulated and proposed, in fact, to be a potential route by which the virus can enter the nervous system is that of the choroid plexus. And in fact, this has been proposed by Madeleine Lancaster and colleagues in studies of the organoids in vitro. However, it's unclear whether this route occurs in vivo. And here, again, the inflammatory media may be sufficient to damage the tight junctions between epithelial cells that then will allow either the virus or the immune cell trafficking in the central nervous system. And again, this route has been very prominent to be involved in the initiation of is in multiple sclerosis, as well as the experimental autoimmune encephalomyelitis, the mouse model, right? And so obviously, basically, the other thing that is important to note is that other viruses that belong to the large family, for example, SARS virus or MERS virus substrains, have been shown to have tropism for the central nervous system, particularly the brainstem. And so this raises an important question as to which of these routes may potentially be the routes by which the virus enter the central nervous system. If it enters the central nervous system, where is it found? And is it associated with a neuroinflammatory phenotype that is seen in other CNS neuroinflammatory or autoimmune diseases? So I'm going to pass now to Kiran, who will talk a little bit about the clinical aspects of the study.
Thanks, Dritan. So, our project goals overall were really to study the neuropathological findings in patients who die from COVID-19. And we were really well positioned because of our really amazing neuropathology group here to do extensive studies, and worked as a large team with clinicians, part of my group, basic scientists, including Dritan and his group, and Katrina and others, to really, I think, have this multidisciplinary approach. We also wanted to look to see, to point to Dritan's points earlier, what the degree and extent of neuroinflammation there was in the brain, as well as whether there was presence of the virus itself. And so did a number of studies to evaluate for that. Next slide. So we included all consecutive autopsies between March and June of 2020 that were meeting CDC criteria for definitive COVID-19 infection. Clinical data, including demographics, clinical lab radiographic data, were obtained retrospectively from electronic medical record review. And we present here the findings, neuropathological findings of 41 patients that had confirmed COVID-19 infection. The mean age of our cohort was 74 years with a range of 38 to 97. 27 patients were male, and there were a high portion of patients, 83%, that were Hispanic or Latinx ethnicity. Dementia or mild cognitive impairment was the most common neurological comorbidity in 8 of our 41 patients by our electronic medical record review. And not surprisingly, many of our patients were critically ill that were admitted to the hospital. So multifocal pneumonia was present in 81%. Can you hit next, please? And next, 15 patients met criteria for ARDS, and hospital-associated complications were very common in our patient cohort. Next slide. So this is a bar graph showing the length of clinical course of our patients, including symptoms prior to presentation, shown in blue, and days in the hospital before death, either in the ICU, shown in orange, or in gray, not in the ICU setting, and in step down or on the floor. And then the dots represent the time of the last positive COVID PCR test by nasopharyngeal swab prior to death. So, this image really, I think, shows and exemplifies the striking variability in terms of hospital course. The average length of hospital stay was 19 days, but ranged between 0 and 69 days. And there were 3 patients who presented in acute cardiopulmonary distress with rapid progression to death. So 8 patients died in less than 24 hours, while 11 were in the hospital for over 4 weeks. The average time of last COVID positive PCR to death was 11.9 days, but there were a number of patients in which COVID PCR was positive at the time of autopsy, 11 of our patients in our cohort. So I'm going to hand it back over to Dritan and the neuropathology team to describe some of our findings. Thank you.
Thanks, Kiran. So again, the neuropathology team led by Peter Canoll did a tremendous amount of work to basically sample a large number of different regions of the brains from these patients. And in this sampling, there were obtained both fresh frozen samples, and those fresh frozen samples were used for our qRT-PCR and this and RNA scope studies. And then obviously the majority of the sampling was processed for regular, H&E and immunohistochemistry to measure the degree of histopathology. And so as you can see here from this list of regions, we basically covered a large number of regions because we wanted to test all our different hypotheses. Obviously, we looked at the olfactory bulb with adjacent tracks because we wanted to see whether indeed the olfactory route was one of the routes. And then various regions of the CNS, including the midbrain and the hindbrain, as well as the choroid plexus. And obviously, we also obtained the nasal epithelium if available for some of the studies, in particular for the qRT-PCR studies. So this is a table summarizing sort of the major histopathological abnormalities that were found in this cohort of 41 cases. So as you can see from this table, all the patients had hypoxia, although hypoxia was basically in varying degrees from mild to moderate or quite severe in a few cases. About 43% of cases had infarcts, and in about 19.5% of these infarcts were hemorrhagic in nature. So in about 92% of cases, we did see a very small but very mild infiltration of lymphocytes. But the most prominent feature of the neuropathology in these cases was actually a large degree of microglial activation that was either focal or diffuse. And we observed this in about 80.5% of cases. And in about 63% of cases, there were actual microglial nodules that, and in some cases, they surrounded neurons. And patients were older in age. There were other associated neuropathologies. And in one case, this was a case that had herpes encephalitis or HSV-1 encephalitis. And so this case turned out to be an important control case where we could kind of compare a true encephalitis case with COVID-19 cases in order to basically see to what degree that there was a similarity and difference. So as I said, in about 19.5% of cases, there were basically hemorrhagic stroke. And these are the images from the radiology team, where you can see here in the left, there are hypointensities in the CT scan. Both these were taken before the brain obviously was taken out. This was actually after the brain was taken out, and you can clearly see here in the gross histopathology the infarcted region. Now, the major pathology that was found actually is this microglial nodules. So here I'm showing you two examples found in the near the hypoglossal nucleus and the dorsal motor nucleus of the vagus nerve. So these are down in the medulla, and you can clearly see here a very small number of T-cell infiltrates that are either CD3 positive and CD8 positive, so cytotoxic T cells that are in close position to basically a large group of activated microglia or macrophages. And in addition, we observed, as described before, these microglial nodules. And in some cases, these microglial nodules were surrounding a particular neuron that was dying. So this is a very good example of neurophagia. And this is work actually from my lab, where we looked very extensively in the pons region in various cases. And here at the bottom is the case that had HSV-1 encephalitis. So this was a clear case of acute encephalitis. And in the top panels are patients that had COVID but didn't have any other HSV encephalitis. And you can see the prominent feature here that was seen in these patients are these like microglial nodules that were both positive for IBA1 and CD68. And in particular, in the COVID-19, in a large number of these cases, this was extremely prominent. In a few cases, we could see a more classical neuroinflammatory phenotype where you could see a large number of cellular infiltrates surrounded by macrophages, activated microglia that were both IBA1 positive and CD68 positive. And this contrasted very greatly with the case of HSV1 encephalitis, where you can see here a very profuse activation of microglia, labeled here with IBA1, as well as infiltrating macrophages or activated microglia, labeled here by the lysosomal marker CD68. So this was not only prominent in the CNS parenchyma, but also when we compared the choroid plexus, there was also a very clear picture. So whereas in the case of HSV1 encephalitis, there was a large number of macrophages present in the choroid plexus, labeled by both IBA1 and CD68, the number of these was relatively small and appeared almost normal in other COVID-19 cases. I want to remind you that typically the choroid plexus has a large number of macrophages that surveil this particular region, but they didn't show any abnormal morphology in contrast to the one in HSV1 encephalitis. Sorry about that. So then we looked at the degree of T-cell infiltrates. And in particular, my lab was quite interested in trying to look at the T-cell infiltrates around the blood vessels, because these are typically seen in other forms of either viral encephalitis or autoimmune encephalitis. And so in the top panels here, what you can see here are the typical representation of what we saw in COVID-19 cases, that usually there is a very small number of T cells that are perivascular with very little to no infiltration in the CNS parenchyma. Also, a very small number of T cells in the choroid plexus. And this, as I said, contrasted very significantly with the HSV1 encephalitis, where you can clearly see here a large number of T cell infiltrates. And you can see that these T cell infiltrates now have penetrated the blood vessel and have entered the CNS parenchyma.
Dritan, you have 2 minutes, okay?
Oh, 2 minutes, okay. I'm just gonna rush here. And there was also a large number of T cells in the choroid plexus. So in parallel to that, whereas in the majority of COVID-19 cases, we didn't see any abnormalities in the basement membrane, we could see that in the HSV1 encephalitis, the basement membrane was disrupted to allow the infiltration of the immune cells. And so the question is there virus present in the central nervous system? So we took 2 approaches. One is to do the qPCR from different regions, such as the olfactory bulb, temporal lobe, cerebellum, medulla, and the superior frontal gyrus in about 26 cases. And this was done in Katrin Suleiman's laboratory. And so this graph here illustrates pretty much our findings in 26 cases. They're basically labeled in bin when you can see the dark color represent the small QT value, and then the light colors or the light gray higher QT values, which mean low viral load. And as you can see here, while the viral load was quite high in the nasal epithelium, the viral load was relatively low in the other organs, in the other regions of the central nervous system. And those data are summarized here. So finally, we wanted to basically see whether we could detect the virus by RNA-scope. And so for this, we collaborated with the Neuropathology team, and basically we performed fresh frozen sectioning of the upper or lower medulla in 16 cases. And these cases were primarily selected based on positivity on the qRT-PCR analysis. And for this, we did the classical RNA-scope approach where we could detect the viral using this method. So in contrast to basically what we saw with the qPCR, we could not detect the virus in the brains by the RNA-scope method. In contrast, we could see very beautiful signal in the vessels of tight junction associated proteins such as claudin 5. And on occasion, we could see basically the SARS-CoV-2 S probe in the blood vessels outside the CNS. You can see here in the basement membrane. In contrast, we could detect super high levels of the virus in basically lungs of COVID-19 patients, showing that indeed this was our positive control. And this is basically a summary of the data, but pretty much we could not detect it with the RNA-scope. And so to conclude, basically, what our data showed that indeed we could see a global or local hypoxic ischemic that is present in the brain. There were infarcts in a subset of these patients and some were hemorrhagic. The prominent feature was basically the microglial activation and microglial nodules accompanied by neuropathy. In contrast, though, to the prominent microglial activation, we could only find a very small degree of T-cell accumulation in the perivascular or brain regions. Blood vessels were almost normal with intact junctions, few perivascular infiltrates, normal basement membrane. And then basically our molecular studies suggest that indeed the viral levels could be very low, detectable by qPCR, but undetectable by the RNA-scope. And so the findings suggest that indeed a lot of the microglial nodules that are present there, although we cannot technically exclude the possibility that the virus may have been in these brains, we think that this is probably largely due to the hypoxic state. And so the key players obviously were Kiran, Thakur, as well as Jim Goldman and Peter Canoll. And then from the two basic biology labs, Ann-Catherine Ullemann's lab did the qPCR studies, and Michael Glendine, and a research assistant in my lab, did a lot of histopathology in the pons and the RNA-scope studies. And obviously this would not have been possible by an amazing neurology and neuropathology team here at Columbia, as well as the radiology collaboration and Robin Klein from Washington University in St. Louis, who provided a lot of advice. Thank you.
Thank you, Dritan and Kiran. We went a bit over, but we have time to entertain one or maybe two questions if any of the audience members would like to raise their hands. If not, I have two, I think, general questions. The first is there any evidence that the neurological symptoms persist in patients after they've been cleared of the virus? That's question one. And the second question is, within the cohort of samples that you analyzed, I think Kiran had said that 34% of the patients had exhibited symptoms of confusion. And I was curious whether within that specific cohort, were there any particular physiological manifestations in the brain samples?
Yeah, so I can take the first part of that question. So, I think that we're beginning to kind of start to look into and understand what some people are calling kind of the long-term effects of survivors of COVID-19. And, personally, I think there's kind of groups of patients, clearly these are the patients who died and were, often very severely ill. and had evidence of multi-organ damage, several of the patients arrested, et cetera. And you can see the evidence of hypoxic ischemic damage. So I think that for those people who may have had, mild to moderate or even, kind of maybe no symptoms initially, we are seeing, anecdotal reports now. And I think there's, a lack of, good series that include kind of cases that have been followed longitudinally post-hospitalization, right? A lot of these clinics are kind of have a component of referral bias of patients that have kind of brain fog and cognitive symptoms. And that's beginning to be studied and looked at very extensively by our neurocognitive group. And then I'll hand it over to the neuropath group and Dritan to speak about the second part of the question.
Eric, can you repeat the second question? I can't
Yes.
remember.
I think the number you quoted was that 34% of the patients whose samples you analyzed had exhibited confusion, I presume upon coming to the hospital. And I was curious whether there were any particular physiological manifestations in those samples that weren't necessarily found in the others.
Yeah, hi, Eric. This is Peter Canoll. I can quickly answer that.
Hi, Peter.
There was no correlation between the neuropathologic findings and any of the clinical presentations. This might be because these patients were all very sick. And so, to answer that question in a more long-term way, we are continuing to collect brain autopsies on patients who had COVID and recovered, and now have some of them having, prolonged or pronounced clinical histories of neurological symptoms. So whether we'll get additional information on that remains to be seen.
Great. Thank you very much. Thank you all for a great talk.